Hello, welcome everyone to our webinar on automating MRI workflows at the point of imaging. Thank you all for joining. It's a pleasure to have you with us. Today, we're focusing on how technological advancements are revolutionizing MRI workflows, offering insights that promise to enhance efficiency and patient care in practices and hospitals alike. My name is Stefan Braunewell. I'm a strategy and innovation advisor with more than 15 years of background in image computing and radiology AI. And with me on the panel today are Harris Schwabe from Guy's and St. Thomas's NHS Foundation Trust, Arnon McCory from Assuta Medical Centers, Dr. Andre Fischer from Siemens Healthineers, Professor Dennis Klomp from UMC Utrecht, and Robert Lauritsen from Cerebriu, the company who is presenting this webinar today for you. Before we begin, let me say a few words about the webinar itself. We will start with a keynote presentation, after which I will be welcoming each of the panelists to our virtual stage with a short introduction statement. And all the way through this session today, you're invited to pose your questions to the panel via the Q&A button that you find on the bottom of this Zoom window. So now we're set for an enlightening discussion, and I'm thrilled to introduce our keynote speaker, whose expertise will illuminate the transformative potential of MRI automation. So Harris Schwabe, he has a background in medical physics with a scientific focus in neuroimaging. He is consultant clinical scientist and head of the clinical scientific computing section at Guy's and St. Thomas's NHS Foundation Trust, where his team are developing people, platforms, and policy for digital health. Harris is also founder and CEO of Newton's Tree, a startup dedicated to AI transformation at scale in health and care. Harris, as you're seeing clinical workflows from an innovation perspective, please lead us through your thoughts on MRI automation. And the stage is yours.
Fantastic.
I will
Thank you, Stefan.
Stop my sharing, and you can share your screen now.
Fantastic. Great. Presumably you can see the presentation. Yeah. Fantastic. So thank you so much, Stefan, and thank you to the Cerebriu team for giving me a very brief opportunity to talk a bit about the context and then the opportunity of AI in MRI workflows, and then particularly how we can innovate around the point of imaging to really unlock potentially a redesigned MRI service. Progress too many slides. Stefan did a fantastic introduction, including my disclosure. So I have a commercial interest in this space through Newton's Tree. I don't think I'm revealing any secrets when I talk about the real challenge we're having, particularly in the UK, but I think this is a system-wide, as an internationally system-wide challenge around providing an effective MRI service across the entire spectrum of secondary care services. But we are feeling this acutely in Europe and even more acutely in the UK from two angles, right? So we have, first of all, a staff crisis, right? For those of you who are sort of plugged into the UK picture, you know that industrial action has been ongoing for almost a year now. And aside from, pay and conditions, there's been a massive increase in the demand for clinical radiologists, and without any significant increase in the number. And the projection from the Royal College of Radiologists is that, just in a few years' time, there will be a shortage of 3,500 clinical radiologists to keep up with demand for services. And the other part of the challenge of delivering the MRI service is machine capacity and imaging capacity. And the UK famously, again, has one of the lowest number of MRI scanners per capita in all of the OECD countries. And so not only do we have, huge backlogs of images and therefore delays in diagnosis and treatment. But we have a challenge at the front door as well, where, long waiting list for even getting access to an MRI service is a challenge. And so if any system is incentivized to innovate, it's the UK. But it's a challenge generally anyway. And if we were to drill down, and I know the topic of the discussion, probably where we will focus is around, imaging and image acquisition and reporting. But I just want to zoom out for a moment and consider the MRI pathway sort of as a whole. And it's slightly idealized. It might not translate in every context, but roughly, the journey starts with a referral from imaging from, a primary care physician or something like that, or some other specialty. And then those referral requests are then vetted, often by radiologists, sometimes radiographers, where they take into account clinical lead, the patient context, potential contraindications. Then protocols are defined for that particular patient or that particular request. They can then be scheduled, taking into account restraints, clinical priorities, skill mix of the staff, etc., etc. Even the capabilities of each individual scanners. Do we have the right licenses on this particular scanner to acquire this kind of image for this kind of patient? Or does the appointment need to be delayed so that we can scan them on the appropriate scanner? And then it gets to the image acquisition process itself. And we'll talk a lot about that, I guess, during this panel discussion. And then finally, I say finally, it's really the beginning of the journey, is reporting and follow-up, and then hopefully diagnosis and treatment. So the opportunity for AI to improve the existing MRI pathway is plentiful, right? There are lots of opportunities, and I've just highlighted some key questions that we've been considering at Guy's and St. Thomas's in particular, but I think are probably just as relevant no matter what the context is, around how we can improve each one of these incremental steps. So, and when we are considering improving each one of these steps in the pathway, there's a simultaneous consideration not only of the impact onto the medical radiologist workforce, but also allied health professionals like radiographers or radiology techs, nursing staff, support nursing staff, and then also considerations from a more system perspective around demand management and waiting lists, and then what impact any improvements might have on productivity. And I'll just a quick sort of whistle-stop tour. The bulk of the focus around improving existing MRI pathway has been massively biased towards the end of it, right? The report, right? So everybody who's familiar with sort of the imaging AI space knows that the vast majority of AI algorithms are all focused on helping the radiologist with their reporting efficiency, either detecting more pathologies or detecting them faster. But there's an incredible amount of opportunity to improve all of those metrics much earlier in the pathway. And there are beginning to be some companies developing products earlier in that pathway. I think it's an Irish company working on referral vetting called X-Wave vetting and protocoling. We've spent a lot of time locally at Guy's and St. Thomas's building in-house products. But obviously a lot of the OEMs and PACS providers and RIS providers provide some tooling to optimize and help with that. Scheduling is a bit of a dark art, right? Strategies around optimizing scheduling range from the sort of very primitive, in that, we're going to do all of our knees on Thursday afternoon, to much more intelligent approaches, but no sort of system-wide solutions that are technology-based. And image acquisition historically has largely been the domain of the OEMs. So any innovation there has come from the sort of large machine providers, and reporting I've already mentioned. But I think there's incredible opportunity if we start paying attention to the entire pathway. And this is where I'm going to propose something radical. We don't have to talk about it for the next hour, but something to think about is there an opportunity for us to completely rethink how an MRI service is delivered, right? Why do we have to do it in this sequential sequence, one after the other? What if we went from straight to referral to inside the scanner? And what if scanning and reporting or image interpretation was simultaneous? And what if image interpretation informed scanning, right? And I'm again thinking particularly about the UK context where the time from referral to the scanner can be 6 months, right? You know, for a an ACL tear or a potential meniscectomy, that could be a 6-month wait, 9-month wait. But what if it didn't have to be? And so one idea that I initially used to consider a bit of a sort of a wild dream, but it's becoming, I think, more of a reality with innovation over the past few years, both in the MRI hardware space, but increasingly in the image analysis space and image acquisition space with companies like Cerebriu and others, is can we get to a position where protocoling, optimization, and when I say optimization, I mean sequence optimization, quality assurance of an image, and then reporting of that image happens iteratively near real time, where somebody can walk into a scanner with non-specific condition, persistent headache or something like that, vague neurological symptoms. And the vast majority of these cases will undoubtedly be negative, but the ones that are positive are critical in terms of time to treatment, because it's a potential glioblastoma, for example. Could we redesign how we delivered this service by getting rid of that middle bureaucratic process? The way that MRI protocoling exists as it does now, the patients receive the entire imaging protocol, even if their query is answered much earlier in the imaging sequence or in the sequence of that protocol. And so you might have this patient in there for 30, 45 minutes, and actually in the first 15 minutes, we know that there are no critical findings. And so then there's an opportunity here to not only shorten the waiting list to getting into the scanner, but once they're in the scanner as well, getting them out as fast as possible. That obviously has benefits around demand management and resource utilization. It also has a massive impact on patient experience, right? One of the big sort of almost unspoken challenges around MRI is patient hesitancy and lack of patient compliance. And being able to optimize and minimize the acquisition process that is focused on fact-finding might allow us to radically redesign how MRI is delivered. And with the right hardware innovations, it might be possible to bring MRIs to the patient. And the sort of dream of MRI in the community, or as I used to call it, MRI in the high street, becomes much more of a reality. And MRI as a diagnostic modality almost becomes similar at a very high level, like a symptom checker, right? And the good thing is, I mentioned that this is not a crazy idea anymore. This used to be a crazy idea when I talked about it in 2016. But now, like I said, thanks to hardware innovations and software innovations, people are now beginning to offer, almost quite literally, MRI scans in the high street, in town centers, not even city centers, in town centers. Just to give you an example, that's relevant to my sort of academic work in glioblastoma, a lot of our patients that are seen at Guy's St Thomas's Cancer Centre can come as far away as from the Kent coast, which can be almost 100 miles away. And if you imagine yourself potentially 70, 80-year-old with a terminal brain tumor, and do you really want to be getting on a train for 2 hours to go into central London, into that rush for a 20, 30-minute scan? What could it mean for patient experience and outcomes if the MRI was as accessible to patients as their local high street? And I'll finish with that, with my closing remarks, and look forward to the discussion.
Thank you very much, Harris. You raised, from your holistic point of view, already so many topics that we'll come back to during this panel hour. I'm very much looking forward to it. So please let me introduce to the round Dr. Arnon Makori. Arnon holds a medical degree from Witwatersrand in Johannesburg and a master's degree in health administration from Ben Gurion. As the Director of Imaging Services of Assuta Medical Centers, he is responsible for the imaging operations of the largest private healthcare group in Israel, with 8 centers and more than 100 radiologists in various subspecialties. He is an expert abdominal radiologist with many professional interests, including new imaging technologies and AI. So welcome, Arnon. We're glad to have you. And with your responsibility for a vast volume of MR imaging, what are, from your perspective, from the clinical point of view, the most pressing needs and your urgent requests for this field?
Thank you, Stefan, for having me along, and I appreciate the wonderful panel of experts that you gathered here, for this Thursday afternoon. And what I think that I will try and give a more down-to-earth, boots on the ground approach of how can we, as a radiologist and as an operational head of operation, head of imaging services in Assuta, can actually look for the future implementation of such solution that the Cerebriu Apollo product has, or similar product. So just to remind all, we are a very busy MRI group. We conduct more than 100,000 MRI scans a year. We average about 40 scans, 40 patients per scans for each day. We are 23/7, 360 days operation. We work, throughout the day and throughout the night. So we are very, very busy. So for us, our goal is to see how can we accelerate and how we can make the whole scanning process more exact and precise. How can we optimize the whole process? And for us, the main issue is the difficult process of protocoling. We don't have a pre-protocoling process, and we depend on our technologists, our radiographers, actually to do the protocol while they're doing the scan, or just before they're doing the scan. Sometimes, and many times, there's no radiologist available to give the medical input. Some of the patients are very complex, and some of the referrals are very hard to understand, the referral letters. So we are actually, we studied and we realized that our patient recall or callbacks is 5 times the amount what is being actually reported in literature. So we'd like to see how can we use high-end technology to reduce our patient callbacks, to optimize the workflow, to make sure we are doing the right scan. A large percentage of patient callbacks is due to inappropriate protocol, about 40%. 20% are being called for the lack of contrast injection. So if we can identify the lesion, and if we can administer contrast at the first scan, so we are actually both decreasing patient callback, improving patient satisfaction, and even can generate even a better revenue. So this is important for us to see how can we optimize and exact the process of the scan and the protocoling of the MRI scan. And this is a very important aim for us for the next year. Now, on the reporting side, we like to see the product, helping us with the holy triads of triage, of detect lesion and of classifying the lesion. This is on the reporting side. So I know the triage and finding the critical lesion, reducing the turnaround time to report this lesion is vital. So we like to implement. We're doing currently in the CT with, with urgent findings regarding pulmonary embolism and incidental pulmonary embolism, brain hemorrhage. We like to take the great success that we achieved in the CT AI implementation and see how can we do it in the domain of MRI. Now, the last thing that I would like to discuss is we need to, or I need to prove, how can we actually measure and how can we define what is a successful implementation of AI technology? So we need to have a whole set, we're developing a whole set of implementation metrics to see if the implementation was successful, regarding user engagement, to see if people, of the technologists and radiologists actually using the product, to see what is the clinical accuracy of the product. Does it actually give the clinical accuracy that it's set out to give, regarding sensitivity and specificity? And the last and most important thing is what is my ROI? What is my return on investment in implementing such a solution? So I need to prove to my CEO that it was clever to spend vast money or good amount of money in buying or in implementing such a solution, and I can prove a tangible return on investment in improving quality, increasing patient safety, reducing recalls. So I need also to give, as the Director of Imaging Services, the financial return on investment on AI implementation.
Wonderful. Thank you very much, Arnon. What a great span of different aspects that we also will come back to. So thank you very much for your introduction from your point of view. I would next like to introduce Andre Fischer. Dr. Andre Fischer, an MR physicist by training. Andre spent 8 years in academic MRI research before joining the industry in 2013. In his pre-development role, he was improving cardiac MRI applications and learned a lot about workflow burdens in clinical practice. Since 2019, he is part of the scientific marketing team of Siemens Healthineers, working primarily on neuro and innovation topics. So Andre, now listening to Arnon, Harris, and you have so many interactions with clinical customers and understand the needs from the clinical side. How do you see from OEM perspective the possibilities or the road ahead for MRI innovation?
Yeah, I mean, I can only mirror what was already said regarding shortage in healthcare, in qualified healthcare personnel. This is something that we hear all over the place. Not only radiologists, but also radiographers, techs, and so on and so forth. So the request that we often hear is the scan needs to be easier, it needs to be faster. So everything that basically Harris already mentioned. As a vendor of the hardware, we don't have the control over this whole pathway that Harris showed. But in terms of in particular imaging speed, a lot is happening at the moment. I mean, AI has substantially changed the landscape in the last, let's say, 4 to 5 years, which can only be parallel to the advent of acceleration techniques around the millennium. And I mean, that helps, of course, to speed everything up, to take away the burden also from the patient, because it was already mentioned, not all patients are compliant. Usually they are for the first time in an MRI, not like me, 200, 300 times. I know how it is, so I'm very relaxed. Patients usually are not. So yeah, these demands that workflow needs to be easier is something we hear very frequently. We as a vendor, we have address that in quite a lot of aspects, be it easier prescription of the scan itself, and of course faster scans in general, making the whole technical setup of the MRI easier. I mean, when you think back 20 years or so, oftentimes you had to manually select coils, for example, which made the scan slots very, very long and tedious, and it was quite prone to errors from the operators. This is something that we, to a quite large degree, I guess we have that under control nowadays, so that already helped. But now that we see this shortage in healthcare personnel, we need to even go one step further, and use it wherever AI makes sense, takes away, let's say, routine tasks that a human operator not necessarily needs to do. Protocol management was also mentioned, that this is also something that we hear quite frequently from customers. There are solutions that we also offer where you can harmonize protocols across various scanners, but this is, this is something that is not always easy to implement. But all these aspects, they help. They keep the burden lower. They make it easier. They make it faster. But there's still, of course, room for improvement, and many of the topics that can be improved have been mentioned already.
Great, thank you, Andre. And we're coming back to these in a little bit more concrete way during our webinar today. So next up, we're looking a little bit further ahead into the future, if you would agree, Dennis. Now you're smiling already. You know that you're the one for this perspective here. But please, whatever the future means for me, if that's tomorrow or in a few years from now, you choose. So let me introduce Professor Dennis Klomp. After a degree in electronics and a few years at Philips, Dennis decided to go for research. With a PhD from Assuta Medical Center in Nijmegen and a postdoc at the High Field MRI Center in Essen, he is now full professor of high precision metabolic and structural imaging at UMC Utrecht, manager research of imaging and oncology, and coordinator of the large research infrastructures medical science for the Dutch Science Foundation. So Dennis, from your research view, when you're hearing all these different aspects of needs and you're looking a little bit further ahead, how do you see the future and the opportunities?
Yeah, thanks for raising the question. And to be honest, I think Harris already laid down a beautiful dot on the horizon, which I completely agree to. But I was also surprised by the amount of patients that Armon was mentioning, 100,000 in his center. And also what Andre was saying on the workflow, indeed, there's a lot of progress going on. So if you think about the trend, maybe we should not only think about making it faster and lower expensive, but maybe we should think about, do we really need the expert technician to run the scan? And let's just envision, right? The question is, how difficult would it be to put a patient inside a tunnel? That's basically the question then, and lay still. And a lot of AI is currently out there that can see if the scan was run correctly or not. So I think that there are a lot of hurdles which are currently maybe still there, but they're really going quite fast to move forward. So, but if that's the case, then the business model becomes completely different, right? For the hospital. I'm not saying for the industries, I'm saying it for the hospital. As currently in the Netherlands, we are allowed to charge roughly 350 euros, right, for an MRI diagnose. And then our financial people say, yeah, we hardly break even at that point. But if you take away the personnel part, and let's say also the very expensive hospital, let's go to the street, put it up there, then the cost for an MRI diagnose, the hardware itself, is like 10 euros, right? So it's a massive, huge gap, right, of margin which is still out there. So I hold a presentation some time ago at a large industry vendor. I'm happy also to see Siemens here represented. In this case, it was Philips. So I raised the question. I'm prepared to pay double the price for an MRI system if we do not need, right, any staff anymore. And that means there's a lot of margin also for the industries to take that spot. So I hope that will be the future, right? Because I was actually waking up during the COVID and see how stressed whole the medical domain is, right? There's nothing needs to happen and everything falls down. We heard in the UK, there's already a shortage of technicians and radiologists. That's definitely also the case in the Netherlands and Germany, as far as I know. So I think if we can solve that issue, put the scanner outside, let everybody go in at much earlier in phase, that would be a future which I think is very realistic and not so far down the road.
Very good. Thank you very much, Dennis. So let's go a little bit more into what's possible today and the road ahead towards these goals that you have outlined. So let me introduce Robert Lauritsen, CEO and co-founder of Cerebriu, dedicated his career to life science, starting as entrepreneur, building mobile dental clinics, spent nearly 2 decades in pharma, improving operational efficiency, and the past 5 years in radiology, focused on transforming workflows with AI. So Robert, could you give us a little bit of an overview of when you hear these different needs and requests, where you see AI being able to streamline or automate these processes, maybe even taking complete actions and workflow steps away from the need of specialized personnel?
Sure. Thanks, Stefan. It's been fantastic already to hear all these insights and visions across our time zone. So we at Cerebriu are building artificial clinical intelligence because we see the future of a clinically intelligent MRI being part of the answer, not the full answer, but part of the answer that can enable more autonomous scanning, more autonomous protocol and protocoling and protocol adaptation, part of what addresses Harris's talk, and also to get it right the first time. But as Dennis talks about, with limiting the resource requirements and the expertise at the scanner. Right. So if you have a high volume center that Assuta is, if we can apply the clinical intelligence at the scanner, detect critical pathology, flag the patients immediately, adapt the imaging protocol to that particular critical pathology, and get it right the first time, the healthcare system can enable the optimal management of that patient. And having this kind of future for these systems, where MRI is distinctly unique in being non-invasive technology, it suddenly can move into the high street. It can be a potential primary care system that can be super cost efficient. Of course, very happy that Dennis thinks that we can double the price of the MRI system by automation, but nonetheless, it can become more accessible to everyone. There's a massive underserved population. And more timely in terms of treatment, enabling treatment, right? So we're all in a mission to manage population health through this kind of technology, and what we want to do is to secure the optimal and timely treatment of critical pathology. That's what we hear about, saving lives and increasing longevity. So at Cerebriu, we're building technology that is augmenting the MRI machine with these kinds of capability, detecting critical findings within the first few minutes of imaging, and adapting from there. And in conjunction with other, like Siemens Resolve or other AI reconstruction technologies, I think it is a possible future, and not a very distant possible future, to go down to a 2 or 3 minute scan. So a screening first, but real-time adaptation and tailoring and personalized the imaging outcome if it's necessary when there is a critical pathology.
Perfect. Thank you very much, Robert. And before now, we've introduced all the panelists on stage, so we're going into the Q&A part, which is a reminder for the audience as well. If you're interested in hearing something specifically, then please don't hesitate to just post your questions in the Q&A. So picking up on these views of the opportunities going forward, of the possibilities of AI, I would love to hear from Arnon a little bit more concretely about the workflow, the needs that your technologists currently have. You already pointed to the need to reduce patient callbacks. So how do you concretely envision by AI technologies, doesn't have to be the Cerebriu products, but your view of what is feasible by automating parts of the process and what this would mean for your imaging procedures specifically.
Wonderful question, Stefan. Great. And I would like to close my eyes and just imagine that an AI solution at the technologies, at the scanner console by the technologies can actually be some sort of like a junior radiologist or maybe a senior technologist. As I mentioned, we have a great shortage of technologists, and many of them are very inexperienced and young, and they need to operate our MRI scanners 24/7, sometimes in the middle of the night, and they are faced a very complex patient or complex clinical question, and they are not really sure what to do. So there I would like to see some sort of the senior technologist or junior doctor be them in the form of an AI solution, giving them support, show them whether the scan is normal, whether there is a lesion. When I say show them, actually highlight them actually the lesion, you know, put it in a box or put it in the heat maps. They want to see the images themselves, and give them the support and the infrastructure, and it's the safety net to decide whether to carry on with a normal protocol, whether to divert into a tumor protocol, whether to inject or not. And a lot, for now, they're actually playing on the safe side. So they are, you know, they do the most expensive protocol for all patients, you know, and that's take a lot of MR resources and MR time. So that's what I would like to see in the first, let's say, year level. In the future, maybe we are talking about radiographer-free scanning, as we mentioned, and even human-free scanning, but that's, you know, this is really science fiction. I still believe, you know, I sit with my radiographers, with my technologists at the console. You need some human input in designing the scan, identify the anatomy, you know, and matching the right scan for the right patient, especially with the abdominal scan. You know, abdominal scan, you have certain breathing instruction or certain triggering, you know, protocols. You need a lot of, you need the human experience. But in the other body part, it's much simpler, and you can rely on a more automated solution. So if I can summarize my hopes, I would like to see it as an AI in the form of a radiographer, you know, support assistants, a senior radiographer, junior radiologist, sitting by the inexperienced radiographer by the console in the form of an AI solution.
Wonderful. Thank you very much, Arnon. A very clear explanation. Andre, from your perspective of the industry and of the big iron provider here, how do you see the actual possibilities of implementing? So we're now going into the space of open innovation, of collaboration, of you opening up to other collaborations. How would an institution interested in these kind of possibilities be able to access them? What's from your point of view?
I mean, for us as a vendor, collaboration, open innovation, they are driving topics because as probably everybody understands, there's only so much that we as a vendor can do in this space. Our big strength is to provide the hardware. This is, and of course, the general sequence environment and how the scanner is operated. But then there are many, many nuances that can be addressed by companies like Cerebriu, for example, but also others that we don't have on the radar right now, and where we simply lack the resources to address them ourselves. I mean, some of the topics that Arnon mentioned, we have at least gone first steps along these paths. So, for example, when we released these lower field scanners, so the free systems with 0.55 Tesla. One big idea behind it was that these scanners should exist in places where no MR has been before, which also means usually you don't have qualified MRI techs. And that meant that standard operations such as neuroscanning need to be very highly automated. We called this autopilot. This is a very, very reduced user interface that you can use here. It does not work across the whole portfolio, of course. Anon mentioned abdominal imaging. It's not, this is a different beast. Cardiac imaging, this is a different beast. These are very difficult exams that you need to do with a very complicated workflow. In particular, when there is no standard anatomy, maybe, when there are some congenital conditions, there's only so much you can automize. So, but it was also mentioned many exams, especially in the neuro space, 90% of all the head MRs are without any diagnosis and not without any diagnosis, but without any pathology. And so you have a lot of routine scanning where you can question, okay, does this all have to be done by a human operator? But there's also another aspect, because the patient needs to go into the scanner somehow. So you will always need some kind, either a nurse, an operator, or whatever, to guide the patient, because it was already mentioned, human interaction, it's crucial. Yeah, I mean, it's a big machine. It's intimidating. It's frightening. People will be afraid, and it's much easier if a human is guiding them, for sure. One other thing that we then heard when we came out with our AI image reconstruction that sometimes leads to scan times of below 5 minutes, that so for a whole exam, not an individual contrast, for example, an ankle you can, or knee, you can sometimes do that in these times. The feedback from the radiologists was, okay, that's interesting, but this is faster than we can set up the next patient. So essentially, in principle, you need 2 hacks again. So it's a very complicated thing, because you make one thing faster, but that might trigger a different problem. And for us as a vendor, because it was mentioned, in an ideal world, we would have a supporting AI algorithm that highlights, for example, lesions. That's a very difficult thing for us as a vendor to get past the regulatory authorities. It's not impossible, but it's a very demanding procedure which is very justified, because you want to be sure that the machine is doing the right thing. But this makes our life very difficult. So it's not that we don't want to have that, but we always have to consider, okay, is this something that we realistically can achieve? And at the moment, I believe the whole industry is in a kind of finding phase. How can we do this, and what is possible and what is not possible, what is critical? But then again, these questions can also be addressed by third parties, which we highly appreciate in that context.
Thank you, Andre. And I would love to hear first Harris, and then probably also Dennis. I'm sure you would have a view on this in terms of the overarching workflows that need to be adapted and need to fit together to make this an actual valuable use case. So if thinking like changing the technologist, the needs for specialized capabilities of the technologist for automating parts of the pipeline, how would you go about, and Harris, maybe you can start with this, how would you go about changing the procedures in the institution to make this an actually valuable change in the overarching system?
I'll just touch on it very briefly, and I'd love to hear some of my colleagues' thoughts. So, I mean, we've tried, I mean, everyone does a bit of automation when it comes to image acquisition to support the radiographer or the technologist, right? We have, automated planning for neuroimaging is pretty standard these days. And one of the effects that we've seen, and is relevant to automation in general, and will be one of the big areas of concern, or if it's not, it should be, is automation bias that automation can introduce, right? And we've seen that happen in certain instances with certain, auto planning features where particularly, and this is common in all areas of domains, where somebody who's not an expert in that domain, but some of our more junior colleagues, pointing to Arnold's point earlier around the workforce is getting younger in MRI radiographers and technologists, and those that cohort is more prone to not I guess being as critical to some of the automated decision making of the scanner or the software. And so then if the hospital still wants to invest in large scale automation, then we have to think about having robust processes in place, not only for validation on sort of day zero before go live, but then continual monitoring and auditing. And the trouble there is, going back to, again, Arnold trying to justify to his CEO, if it requires, an extra staff member to then do the auditing and the monitoring and double checking and the recalls, then from an economic perspective, is the business case still viable in investing in this technology? And that is one of the things that troubles me. Again, it's not necessarily specific to MRI, it's general in AI in healthcare, the automation bias risk. But particularly, you can imagine, particularly with neuroimaging, the penalty of having to rebook someone because you misacquired an image, and particularly in the UK context, when that rebooking might then take weeks, is sometimes an intolerable mistake. And so that's one of the challenges I see from institutional adoption.
Mm-hmm. Dennis, would you like to add your point of view? You mentioned that you're very well staffed in terms of technologists. So what would a procedure supporting parts of the pipeline by automation, how would you even be able to kind of monetize this, or to get the value out of this? What's your view on this?
Yeah, I first like to respond to some of the questions some of the statements that were made before, right? And never being able to see a patient getting in without human interaction. Mm-hmm. And one of the discussion was to say, yeah, the scanner is so scary. So I think the big vendors should work on that approach first, right? To make the scanner not so scary. And then note that there is a large margin available for you to do so, right? It doesn't have to be extremely low cost again, but nonetheless, that was first thing I'd say. And the other thing which you have to do is demonstrate. We also heard some cases are easier to automate than other cases. Now I have in a luxury position that we also have a lot of MRI scanners. We have 17 in our hospital, so I have the luxury, right, to select specific groups which can go to another system, right? So let's say brain scans, as were mentioned before, preferably even the ones without contrast, right? They could go to a specific system. But even that is not enough, right? Because we have a hospital with many technicians, so who would believe that we did this without trained staff? So then we have now a new project, right, where we actually put an MRI system inside an elderly care facility where there is no staff, right, in radiographies and so forth. Obviously, we have a remote technician available in our hospital who at least can do it at the transition phase, the first steps, because otherwise everybody got scared. But this is a way, right, to slowly put it into practice only for the parts where it's seen easy. And the patient management, we just put the patient on a chair. The chair automatically goes in the tunnel. Inside the tunnel, there is already the coil, right? So there is no handling needed. And I understand that it sounds maybe a bit not fair because you only do brain scans, but it is a way at least to show that the future is not so far away. Mm-hmm. So I'm not sure if that answers your question, but I think this is what I'd like to say.
Yeah, but it's an interesting side aspect. So what you're mentioning is the opportunity of having completely different places and workflows enabled by these technologies. So let me ask, I've looked through the questions from the audience already, and one, and that is specifically, can any MRI exam be automated? I think we have already answered in parts that there are certainly more difficult exams that may not be first in line. Another question that we have here is, related to what we're discussing right now of taking away parts of the tasks. And there is a question related to this. How do we overcome the aspect of potential de-skilling? So this is open to the round. Who would like to take it? I think there can be very different aspects of this, whether it's even a problem or a problem that we have too few skilled workers. But it's an interesting aspect that I'd like to, and Harris is already raising your hand. So please, what's your view on this?
Yeah, sorry, I didn't mean to second guess any of my colleagues, but only because I've been having conversations around this recently. And again, I'm going to slightly broaden it out. So I think this is a very serious issue from a system perspective. And when we talk about the ethical issues of AI, we often talk about, data governance and privacy and bias and things like that. But I think this potentially has the most wide-ranging impact because the first thing to say is that inevitably any introduction of technology is always imperfect. Like it would never solve the problem for 100% of the population, for 100% of the use cases. Even in really good penetration or adoption, Wi-Fi, the smartphone, we're still only talking 90-95% globally. The question then begs itself is what happens to the others, right? And the problem is that with any skilled profession that is replaced or de-skilled through automation, historically, what often happens is that people leave the profession, and the ones that stay become rarer and more difficult to access. And often then the ability to access those skilled professionals is only reserved for people that can afford it. And so the real challenge I have is that with the introduction of this increasing automation, it's great that we might then make MRI much more accessible to a much wider cohort. But for the cohort for which it's not accessible, for whatever reason, whether that technology is not good enough or some other sort of contraindication, how do they get serviced? And if there are no accessible radiographers anymore, if they're only accessible if you have very expensive private insurance or only if you live in certain countries, then what happens to those people? And so, yeah, in short, I think it's a very serious problem that needs to be looked at carefully. And I think it's the job of the professional societies, the Royal Colleges, the RCR, the ACR, people like this, to really think about, the staffing and professional skill impact of introducing these technologies.
Right, Dennis?
Yeah, I'm sorry, Harris. I think I disagree a little bit, but that's also the idea here that we should. I actually think the whole reason why we do this is there's a shortage of staff, right? And I hope by all of these techniques, let's say if we can already do 50% of all of our, let's say, work automated, and then the other 50% then gets way more energy, gets way more attention, right, from the specialists that actually should deserve that specialism from those technicians. I also noticed that we have of course, we have a large group of technicians, but if it becomes so easy for them, it's also less interesting for them to stay in this profession, which is also scary because then they pick another job. But if you can focus them to really the difficult cases, it's also more interesting for them. And I think currently it's so overloaded that people do not have time anymore to work on the complex cases. And I think that's more a concern than let's say getting detrained, or how was it mentioned by AI? There's plenty, there's too much work to do anyhow. So that's my 2 cents.
Interesting. Now, Andre, you raised your hand next.
Yeah, no, I would definitely agree with that. I mean, when we as a vendor introduced automatic slice planning, for example, similar concerns have been raised. The goal was never to replace the tech, but to basically allow the tech to focus more on the patients, because this is also something that they frequently complain about, that because the machine is so complicated to operate, they basically, all they do is they get the patient in as quickly as possible and get him out as quickly as possible, because you need to make the money, of course. And I mean, if the operation of the scanner in the end is not that difficult anymore, then these people can also, I mean, some will leave. Yeah, that was already discussed. There will always be a place for very specialized techs, be it in abdominal, cardiac, or any other specialty, because there are other conditions that at the moment an AI cannot handle. But then there will be others that simply enjoy spending more time with the patients and doing more what might have triggered them to enter this profession in the first place.
Thank you, Arnon. You have a view on this as well?
I agree that introducing more technology, whether it's AI or other technology, actually will give more time for the technologies to be patient-centric, to be focused on the patient, to be focused on the pathology, to actually learn and study the input that you get from the device, from the AI system, from other sources, you know. This is very vital. And just if you can equate it to what's happened in airplanes, you know, introducing automatic pilots to, you know, airplanes did not reduce the number of pilots, you know, actually made more planes accessible and more flights accessible to a great portion of the population. So for us, the whole beauty about technology is actually expanding it to a greater population, make there greater ease to use it, you know, and to implement it. And that's what I see the potential in having such a support for the technologies by the MR console. You know, this is the great potential. Make it accessible for all, a great portion of the population.
Robert, would you like to add something as well?
Yeah, sure. Thanks. I think actually Anand's analogy was quite good. I was going to say something like, you know, we now have everyone can take great pictures, but they're still photographers, right? 20 years ago with analog cameras, I was pretty much crap at taking pictures, and I think most of us probably were, unless you were really enthusiastic about it. So I think the democratized access to advanced diagnostic imaging will only be supported in a world where we know that we have way too few experts. And this is a way to overcome our desire to provide better healthcare.
Great, thank you. And Harris, you raised your hand as well. A short answer, please, because then we will come into the final round.
Yeah, just a final, based on that, I love the feedback from the colleagues. So I think I agree with what everyone says, but I guess it's about the entire sort of technology adoption curve. And I would consider some of the digital technologies or autopilot on planes more advanced. But if we think about other older industries like cobblers who make shoes and clothes, now all of our clothes and food are factory farmed and factory made. And it's a lower quality, and the economic drivers, once you have large scale automation and industrialization, unfortunately drive you to deliver the lowest quality tolerable by the end user. And that's my slight fear, is that yes, we'll have a great accessibility, like get a t-shirt delivered tomorrow from China, but how long will it last? How many times can I wear it, compared to before when it was handmade, and now I can't find anyone to hand stitch a shirt for me.
Right. So I think this was a very broad view of the different perspectives. And now let's be a little bit, as the final round here and a short statement from each of the panelists. I would love to be a bit specific and concrete. What is the number one advancement and the number one benefit that you would like to see in the near future? So the next big thing for you and your institution personally. So I don't know, Arnon, would you like to take this first? Is there like your top wish?
Optimize my workflow, enhance my reporting, and make sure that I can measure the success. You know, that's it.
Okay.
It's
Very simple.
it's in one sentence, but it's a whole, and we need one another, it's all interdependent. It's the whole domain, you cannot just take one point. You have to see the whole picture.
That's right. Thank you. Dennis, can I ask you next?
Yes, I think still remove the expert technician and replace maybe by a little less expert technician. That would be a first start.
Perfect. Andre, what is your view?
Yeah, I think for us as a vendor, we need to, and we will embrace these technologies and roll them out where it makes sense, and where it is also safe. That's all, of course, a big concern for us. But as I already mentioned, we are very heavily regulated for good reason, and so we always need to keep that in mind as well. But I agree with everything that has been said. Yeah, we're working hard to make that happen. Yeah.
Thank you, Andre. And Robert?
Yeah, I think the short is autonomous MRI for all.
Well, okay, but
that's so obviously working with Siemens and other vendors on making that happen, so it becomes a single-click operation for the reduced tech requirement, but also precision output, right? So it's accurate and it's only the necessary output, and not sort of the 30 or 50-minute scan every time, because it's quite often not necessary.
Great, thank you. I was just going to say a little bit shorter term focus, but you came back to that. Thank you, Robert.
But we start with the brain, so I think that's the short term. Yeah.
Okay, very good. And Harris, we started with you and your keynote, and you also have the final word on this question. What is your number one wish for the near future?
I mean, the thing that I just remembered was, so last year my newborn daughter was scanned on a hyperfine scanner in a room at St. Thomas's Hospital. When I started my career in MRI physics, that happening in that short time period did not seem realistic to me. So I think the really exciting thing in MRI in every aspect is that the pace of research and innovation is mind-boggling compared to the rest of healthcare. And I think that, and I would call it near term, having widespread MRI in the community, in the high street, is a real possibility.
Wonderful. What a great and optimistic outlook. So for me, it just remains to say thank you to all of our great panelists today. We got very different views and perspectives on this topic of automating workflows in MRI. And to say thank you to all the attendees, also the ones who were asking questions, and the great participation here. I see that a big number stayed until the end, which is a very good sign that we had some very interesting topics to share here. So I'm very grateful for that. I wish you all a nice evening or day wherever you are, and look forward to the next event. What I want to point out is not a next event webinar, but the ECR. So I hope you can see my screen. So Cerebriu is going to be present at ECR as well. So this is an invitation to drop by and engage in conversations, picking up on points that we have discussed today in the webinar. So also to the panelists, please come by and have a cup of coffee so that we can take these conversations further. So please reach out, and we're very much looking forward to seeing you all at ECR. I will be at ECR myself as well. So very much looking forward to these conversations. So thank you very much again to all the panelists and the audience, and I wish you a great rest of the day. Bye-bye.
Thank you. Bye-bye.
Bye.